This is Joanne Lamoureux. I'll be narrating a PowerPoint presentation regarding the anatomical considerations of local anesthesia. I think the first thing that we need to do is get reacquainted with the bones of the skull. These are the bones that are visible from the anterior view. I'll go over them briefly in this diagram. Starting at the top, the frontal bone, we only have one of those. On either side of the frontal bone are a set of paired parietal bones. Coming in an inferior direction, you'll see an orange bone here in both eye sockets and on the other side of this eye socket. This is all one bone. This is the sphenoid bone. This little piece on either side, and most of what you see in the eye orbit, is part of the greater wing of the sphenoid bone, and the upper piece is part of the lesser wing of the sphenoid. Here are your paired nasal bones. I'm sure you'll recognize this bone-colored bone as your right and left maxilla. The opening for your nasal cavity, our cheekbones, are the zygoma. I'd like to call to your attention how, when you look at the skull from this view, you'll notice how the zygoma dips down and goes behind the maxilla. This becomes very important later on for you to recognize, because when you're giving an injection on the posterior part of the maxilla, this sort of hangs down and gets in your way. This is called the zygomatic strut. I'll show you this from a different view in just a little bit. These are your paired temporal bones. This is the mastoid process of each temporal bone, and of course I'm sure you know that's the maxilla. Let's take a little closer look at the eye orbit. These are the 7 bones that make up the eye orbit. You're looking at a left orbit here. The bones are colored so they're a little easier to identify. This is the frontal bone that makes up the upper rim of the orbit. The lateral wall, or the outside of the orbit, is the zygoma. The bone you see in green is our maxilla. And I'd like to call to your attention the fact that a fair piece of the maxillary bone protrudes in and forms the floor of each of our eye orbits. It's important to take note of how much of the maxilla goes inside the eye orbit, because we do put some anesthesia here, and we can get soft tissue anesthesia in the floor of the eye orbit as a result of that anesthetic diffusing backward up inside this opening, which I'll explain to you what that opening is in just a minute. Here's the nasal bone. This is the lacrimal bone, the ethmoid bone, and here is the greater wing of the sphenoid extending up behind the eye orbit, and the lesser wing of the sphenoid. This little white piece that number 12 is pointing to is actually a very small piece of the palatine bone. There are several landmarks within the eye orbit that you need to be aware of. There's in some skulls, actual foramina, or small opening right here. In many skulls it's more like a notch. That would be the supraorbital foramen or supraorbital notch. Inside the skull you'll see 3 openings. A round opening that's on the medial or inner wall of the orbit. This is the optic canal. This is where the second cranial nerve, the optic nerve, comes in from the brain into the back of the eye orbit. There are also 2 fissures inside the eye orbit. If you look closely, you'll see that it almost makes a sideways V. They look to be the same or all one piece, but they're actually not. This is called the superior orbital fissure. It's just lateral to that optic canal. It's anatomically located between that lesser wing and the greater wing of the sphenoid. That's not a real important thing for you to remember. But what is most important for you to remember is that there are 3 cranial nerves, 3, 4, and 6, which pass through this opening. Those are the cranial nerves that allow us to move our eyeball in different directions. The 4th cranial nerve that passes through here is the first division of the trigeminal nerve, which is called the ophthalmic nerve. So I think it is important for you to remember that the first division, or the ophthalmic nerve for the trigeminal, comes into the skull through the superior orbital fissure. The opening that you see on the bottom is called the inferior orbital fissure, and this one, of all of the ones that I've talked about so far, is definitely one that is most important for you to recognize where it is and its significance. You'll notice that the little forceps here is pointing to it, but if you look closely, just in front of it is a groove. So this slide is showing you how that groove is called the infraorbital groove. It lies along the floor of the eye orbit. And if you could imagine yourself being small enough to fit in that groove, on the other side of it right here where I'm pointing is actually an opening. That's an opening to what is called the infraorbital canal. If you were to get inside of that canal, you would come out the other end at the infraorbital foramen. This is a very important landmark for you to recognize and be able to palpate and locate on your patients. If there were actually an eyeball in place here, you would be able to see that if you drew a line straight up, in most people, this foramen is in direct line with the center of the pupil of the eye. So when we teach you how to give an infraorbital injection, this will be your deposition site. And you'll be taught how to locate the pupil with your patient's eyes straight ahead, feel for the lower rim or the infraorbital margin of the eye orbit, roll your index finger or your thumb in a downward direction, and actually locate this foramen. So again, it's important for you to know that the infraorbital nerve, which is a branch of the maxillary nerve, comes through this opening, the inferior orbital fissure, lies in that groove, and enters a channel of bone that's connected from that groove to this foramen. While it's in that groove, it actually splits into two branches that come down through the maxilla. The third part of it comes right out this foramen. There are a few other landmarks that we see when we look at the front part or the anterior view of the maxilla that are important for us to recognize in anesthesia: the canine fossa and the canine eminence. By looking at this diagram, I'll point out to you that all of our maxillary teeth have a prominence or an eminence to them from the facial or buccal aspect. That's because the bone here on the maxilla is very thin and porous, so that I'm sure you're well aware when you feel your patient's marginal gingiva here, you can actually feel the prominence of their root. The canine has the most prominent of all of the maxillary teeth, so that the canine eminence becomes actually what you feel as the root of that canine tooth. When you give certain injections, you'll be taught to feel for the canine eminence, go to where you believe the height of the maxillary canine tooth is, and then just sort of roll your finger in a lateral or sideways direction away from the patient's midline, and that will take you to the canine fossa. So the canine fossa is just a depression that is slightly lateral to the prominence or eminence of your patient's canine. Other landmarks of the maxilla that you need to be aware of are the infratemporal surface and the posterior, this is supposed to say posterior superior alveolar foramina. Let me give you a little orientation here. You're looking at a skull, the lateral view or the side of the skull. This would be your maxillary molars. This is what you call the maxillary tuberosity. And the infratemporal surface of the maxilla is just this, where the tuberosity goes upward. What you're looking at right here is the lateral pterygoid plate. So this is where the lateral pterygoid plate meets the infratemporal surface of the maxilla. This bone hanging down right here is your zygoma. This is the body of your zygoma, and at the beginning I mentioned how this piece of the zygoma hangs down and will become important for you to recognize its location when you're giving an injection called a posterior superior alveolar injection. This is your deposition site. So you have to be able to feel for this part of the zygoma as it hangs down. We call it the zygomatic strut, and you'll notice it comes down and then goes in an upward direction. So you'll be taking your finger and walking it along this strut, and when you reach almost the height of where it goes back up again, you will know that's your target site for the posterior superior alveolar foramina. The nerve that comes and brings sensory information from the third molar, the second molar, and most of the first molar enters the maxillary bone through tiny openings right here where you see this probe pointing. That's the location of the posterior superior alveolar foramina. I'm sure that you're well acquainted with the maxillary sinus. This is the largest of the sinuses that are accessory cavities to our nasal cavity. This is quite a large opening in our skull. It runs from the distal part of our maxillary canine all the way back beyond, in most individuals, the second or third molar. The floor of the sinus sits right above the roots of our maxillary teeth. But what's most important for you to recognize in administering local anesthesia is that the nerves that run from the anteriors, the premolars, and the molars all pass up through this sinus on their way to bring messages to the brain. On their way there, they also have sensory nerve endings that serve the mucosa of this sinus. So if we anesthetize those branches, which are the posterior, middle, and anterior superior alveolar nerves, oftentimes the patient will be partially anesthetized inside the maxillary sinus. Our hard palate, I'm sure you recall, is formed from our maxillary bones and our palatine bones. These are the two pieces of those bones that form our hard palate. I don't think anybody's going to ask you specifically what those two pieces are, but it's very important for you to recognize both the incisive foramen and the area of the hard palate that we call the premaxilla. This is our median palatine suture that joins right and left maxilla. And in the anterior part of that suture is a very noticeable opening. This is where your patient's incisive papilla is normally located. This also becomes a deposition site when you're anesthetizing the soft tissue in the region that we call the premaxilla. If you look carefully at this slide, you'll notice that there is a suture line right here. Now we have only a right and left maxilla, so this isn't an extra bone. But when the maxilla is forming embryonically, there is an anterior piece to the maxilla that joins this piece. So in many individuals, there's a suture line. So we call the area of the hard palate from approximately the vicinity of the canine on one side to the canine of the other, the premaxilla. This is important to remember because the nasopalatine nerve comes down from your nasal cavity and out through this opening, bringing sensory messages from the area of the premaxilla. So again, you're going to be taught to put anesthesia into your patient's incisive papilla where it will diffuse backward into the incisive foramen. The area of anesthesia that the patient will get from that injection, a nasopalatine injection, is soft tissue of the premaxilla. Two other very important landmarks that we see on the hard palate are the greater and lesser palatine foramen. The greater palatine foramen in most people is usually, oh excuse me, I thought that was another slide here. Let me go back. The greater palatine foramen is usually slightly posterior to the maxillary second molar. It's about 1 centimeter toward the midline, maybe 3 to 4 millimeters anterior to the border of the hard palate, where the hard palate joins the soft palate. So when you look inside your patient's mouth, take a look at the tissue color change between the soft palate and the hard palate, and eyeball about 3 to 4 millimeters forward from that point. That's the location of the greater palatine foramen. There is one on the right and one on the left. The other thing that you will be taught is to take a Q-tip, get in this general vicinity, and just sort of probe very gently against the tissues here. The tissue will blanch until you reach the point where you've actually found the indentation for the greater palatine foramen. You'll be taught to place anesthetic in the vicinity of this foramen because the greater palatine nerve comes out of the foramen and brings sensory information from the midline of the palate all the way up to the premaxilla region. So all of this soft tissue that covers the bone here is served by the nerve known as the greater palatine nerve that leaves this greater palatine foramen. You'll notice that closely located in a posterior direction are smaller foramina called the lesser palatine foramen. The lesser palatine foramen is the opening for the lesser palatine nerve. Lesser palatine nerve brings sensory information from the soft palate tissues, or most of the soft palatal tissues, which are sitting right here, And you should be able to recognize that when you put anesthetic in this region, it's going to diffuse inward, but it's also going to diffuse forward and backward. And so if enough anesthetic diffuses around the lesser palatine nerve, the patient's going to have some anesthesia of the soft palate. That can cause some people to feel slightly uncomfortable. They might think that they can't swallow because they can't feel, when indeed they can swallow. The muscle, it doesn't anesthetize the muscles in this region, just the tissues. Pterygomaxillary fissure is a little bit difficult to visualize without having a skull in front of you. I'll do my best here, and I'll just tell you that when you do come in for the clinical portion of this program, we will have some skulls available. If you want to ask any questions with the skull there, it's a little bit easier. But the words say that the pterygomaxillary fissure is a V-shaped slit where the maxillary tuberosity joins the lateral pterygoid plate. So here is the maxillary tuberosity. This is that infratemporal surface of the maxilla that I pointed out before. This is the location approximately of the posterior superior alveolar foramina. So the maxilla joins this piece of the sphenoid bone. This is called the lateral pterygoid plate. This is called the medial pterygoid plate. These are the two legs that hang down from the sphenoid. Where the lateral plate meets the maxilla, it does so in the shape of a V. And it's a slit-like opening, so that's why it's called the fissure. The fissure itself isn't really what's overly important for us, but if you notice here, the diagram is pointing to something called the pterygopalatine fossa. Again, if you were small enough to get inside this fissure, you would notice when you got in here, you would fall into a depression. Anatomically, most of the time when we meet up with something that is a depression, we call it a fossa. Here's a picture of a real maxilla and a real sphenoid bone. Again, this is the lateral pterygoid plate, maxillary tuberosity, infratemporal surface of the maxilla, and this is the pterygomaxillary fissure. Where you see number 11 located right here is actually the pterygopalatine fossa. The pterygopalatine fossa is a depression that's actually located between this lateral pterygoid plate and the palatine bone, which sits on the other side of the maxilla here. The reason that the pterygopalatine fossa becomes important is that you're going to read and learn about the maxillary nerve coming down from this part of the brain. This is the hypophyseal fossa, where your pituitary gland sits. And if you come laterally or sideways from that, there are three openings that we're going to learn about. One is the superior orbital fissure up here. The second one is the the foramen rotundum, and the third one is called the foramen ovale, which sits posterior to that rotundum. So envision that the maxillary nerve is sitting right here, sends its major nerve trunk down through that foramen rotundum, where it drops down into this pterygopalatine fossa. So when you hear about the maxillary nerve having pterygopalatine branches, this is where those branches are located, and they're so far up there that they're not really accessible to us. These are the words that basically go along with what I said. This fossa is a cone-shaped depression that's inside that fissure. And if you crawl inside that fossa, it's going to take you to something called the pterygopalatine canal. That's where those pterygopalatine nerves are located. If you entered one end of the canal, you would come out the other end through the greater palatine foramen and the lesser palatine foramen. So let me just back this up and help you envision. The maxillary nerve goes through that foramen rotundum, and the main nerve trunk drops down into the pterygopalatine fossa. One part of it enters the pterygopalatine canal right here and comes out onto the hard palate, which you can't see from here, at the greater and lesser palatine foramen. These are the three bones pulled apart. So here's, if you can envision, here's the lateral pterygoid plate, here's the maxilla. They join on the outside, but in between them is that palatine bone. Again, this is another blow-up of it. This gives you a little better idea of the location of the pterygopalatine fossa. So the pterygopalatine canal is up here, and the other end of the opening is here at the greater palatine and lesser palatine foramina. The infratemporal fossa is a depression that's located underneath what is called our temporal fossa. It's very difficult to explain what the infratemporal fossa is on the internet like this, and much easier when I have a skull sitting in front of all of you. But what's important for you to recognize, I think, is the infratemporal fossa, even though it's not this major depression where I can say, put your finger here and you'll recognize it. It's basically an area where the muscles of mastication pass through, the maxillary and mandibular nerves pass through it, and the maxillary artery passes through it. And a lot of our injections on the posterior part of the maxilla and on the mandible, our needle is passing through some piece of the infratemporal fossa. So we need to know about it, just because we need to know we're putting a needle in an area where there are not only nerves but blood vessels and muscles. The landmarks of the mandible are extremely important for us to get reacquainted with before we begin anesthesia. Some of them are more important than others. I have them listed here, and I'll use the next slide to point out the ones. So this says mandible from the lateral view. So that would mean if you're looking at the mandible, the lateral view is any landmark you see on the outside of the mandible. So first of all, this piece of the mandible, the U-shaped portion, is called the body. The alveolar process, as you know, is the part of the mandible that holds the roots of our teeth. The ramus is this whole big piece that sticks up in a vertical or vertical oblique direction from the body itself. Where the ramus joins the body of the mandible, we call it the angle. Our mental protuberance is what number 12 is pointing to here. This is just the most prominent part of our mandible. And where the right and left mandible, or the right and left side of the mandible join together, the bone is thickened right here. So the symphysis is where embryologically, well, I don't know, when you were an embryo, your right and left mandible formed as one unit. And where they form together, the bone is thickened. That's where the symphysis is. The external oblique line is this thick part of the mandible right here. This is the external oblique line on the other side. And I'm sure that you've seen many times this in x-rays, because when you look below the roots of your mandibular molars, you see a white line right here. That's your external oblique line. Retromolar triangle is this area behind each of the last mandibular molars that are present. The projection, you have two projections here, number 1 and number 4. This is the condyle of your mandible. This is the part of the mandible that articulates or joins together with the temporal bone to form your TMJ. The forward projection is called the coronoid process. And you'll notice that when you go from the condyle to the coronoid process, there's a very noticeable downward and then upward slope. So again, this is a depression. This is the mandibular notch. If you slide up the condyle and then come along the anterior border of the ramus, number 5 is pointing to one of your most critical landmarks for giving a good inferior alveolar block. This is called the coronoid notch. This is something that you need to become very well acquainted with, how to feel it and where it's located. And the reason for that, again, to find the coronoid notch, you find the external oblique line, go with your thumb or your index finger up the anterior border of the ramus, and you will feel that the bone goes inward and then starts to go outward again. At the deepest part of that inward depression is where you want to be able to locate your thumb, or the middle of your thumb. I'll demonstrate over here. This is basically the height of the coronoid notch. If I take my cursor and I go in a direct backward line, I come right upon the mandibular foramen, which is number 15, is pointing to the opening of the mandibular foramen. So when you give anesthesia on the mandible and do an inferior alveolar block, you're going to be taught to put your thumb in this coronoid notch and keep it parallel to the occlusal plane of your patient's teeth. That's because if you take a line from the middle of your thumb and you go backward, you're right in the vicinity of the mandibular foramen. Here is a slightly better picture of all of this. There's your condyle, mandibular notch, coronoid process. This is your external oblique line. This is your internal oblique line. It starts up here and comes down the inside of the ramus. Here's your coronoid notch, and you'll notice, again, if you follow backward, you come right to where the mandibular foramen is. So looking on the inside of the mandible, you have the mandibular foramen. This is where the inferior alveolar nerve actually enters the mandible. You also have a prominence or projection right in front of that opening. This is called the lingula. And the lingula is a point of attachment for a ligament that's part of the temporomandibular joint called the sphenomandibular ligament. It starts from here and runs up onto the sphenoid bone. And the reason it's important is when we're giving anesthesia, this is our target site or a site of deposition. And if we come too anterior or too medial with our insertion, we're going to bump into the lingula and we won't get anesthesia because it won't diffuse back and into that foramen. While I have this slide up here, it's a real good time to look at the fact that there is a groove that runs right here. Just underneath the mandibular foramen, you'll see a little channel, a groove in the bone. This is called the mylohyoid groove. A little bit later I'll be talking about the inferior alveolar nerve entering the mandible here, and in the same vicinity the mylohyoid nerve is a branch of the mandibular nerve in that same location. The mylohyoid nerve is headed for the floor of the mouth, and it runs right in this groove. So this groove is called the mylohyoid groove. If you follow the groove downward, there's a thickened area to the bone right here, which is what the mylohyoid muscle attaches to. So the groove is called the mylohyoid groove, and the thickened area in the bone is called the mylohyoid ridge. So again, here's the mylohyoid groove. Here's the internal oblique line, and right under here starts the mylohyoid ridge, where the mylohyoid muscle from one side to the other attaches to itself. I have to back up. I'm not sure that I actually mentioned number 10 here when I was looking at the lateral view, but I bet that you all know what it is anyway. This is the mental foramen. Again, another critical landmark. So if you're remembering anything about the mandible, you want to remember coronoid notch, and the fact that the coronoid notch, the middle of it, is in line with the mandibular foramen, which is on the inside of the mandible. The lingula sits just anterior to it. Inferior alveolar nerve enters the mandible here. The mental nerve comes out of the mandible at the mental foramen. So you want to remember that in most people, anatomically, the mental foramen is located below and between the roots of the first and second premolar. If you remember, I said that our infraorbital foramen up on our maxilla is in direct line with the pupil of our eye. And in most people, anatomically, if you locate the pupil of the eye and you come straight down, you will go through the infraorbital foramen and be right on top of the mental foramen. So what I'm saying here is the mental foramen and the infraorbital foramen in most people are in a direct line with one another. The mental foramen becomes a critical landmark because this is the other place where we have a potential to put anesthetic to cause anesthesia. The mandible is very unlike the maxilla in its density. This is a much thicker bone, and that's why we can't do infiltration very successfully on the mandible. The anesthetic won't diffuse or pass through this bone. It's too dense. So we have to put the anesthetic only where we have an opening, and we basically only have two openings at our disposal. One is here, the mandibular foramen, so there'd be a mandibular foramen here and one on the inside of this ramus, and the mental foramen, one here and one on the other side. The other thing that you need to understand about the mandibular foramen and the mental foramen is that they are either ends of what is called the mandibular canal. So what I'm saying is the inferior alveolar nerve enters the mandibular foramen, passes down this way in the bone, and runs underneath the roots of these posterior teeth. So again, the mandibular foramen is on the other side here. It opens up into a channel of bone called the mandibular canal. The mandibular canal comes down the ramus, underneath the roots of these molars and premolars, and this is the end of the mandibular canal. So one end is the mental foramen, and one end is the mandibular foramen. It looks like this. Oops, sorry, let me forward here. Here's the inferior alveolar nerve in the mandibular canal. The mental nerve comes out the mental foramen, and the rest of the inferior alveolar nerve from this point forward becomes known as the incisive nerve. Let me back up here. The other landmarks on the inside of the mandible, there's the mandibular foramen. This is the mylohyoid ridge or line. And then we have a couple of landmarks here. There are little spiny projections right here called the genial tubercle, and above each genial tubercle is a little foramina called the lingual foramen. It's too small for us to use for anesthesia. But I just want to point this area of the mandible out to you because the inferior alveolar nerve enters the mandible here. But in the same vicinity, the lingual nerve is passing in front of the inferior alveolar nerve. It never goes into the bone, but it's traveling in front of that inferior alveolar nerve, coming down like this on its way to the floor of the mouth and the tongue. The mylohyoid nerve is in the same vicinity, but it goes down and backward along that mylohyoid groove because it's headed for the mylohyoid muscle, which is sitting right here. Before we totally leave the skull behind, we're going to take just a quick look at the interior of the skull because we need to know about the cranial fossa, most importantly the middle one, and the three openings known as the superior orbital fissure, the foramen rotundum, and the foramen ovale. You want to take note of the fact that it is the middle cranial fossa that is most important to us because that's where the originating cell bodies for the trigeminal nerve begin. So when we look at the skull, with the skull cap removed, this is the anterior cranial fossa, this is the middle cranial fossa, this is the posterior cranial fossa, and our brain is sitting in there. What's most important to understand about this view of the skull is that this is the vicinity where the ganglion, known as the semilunar or trigeminal ganglion, is housed. It sits right here and right here. And as you'll recall, there are three divisions for that nerve. Ophthalmic goes through the superior orbital fissure, which is underneath this little ridge of bone right here. The maxillary goes through the foramen rotundum, which in this skull is these two openings that you see here. You'll notice this skull isn't particularly symmetrical. And behind the behind the foramen rotundum is the foramen ovale, which is very noticeably an oval in shape. There are several muscles that we have to reacquaint ourselves with. The muscles of mastication and the buccinator muscle. The four muscles of mastication are the masseter, temporalis, medial pterygoid, and lateral pterygoid. Some people learned internal and external. It's important to remember the names of these four muscles, and also more important to remember that all four of these muscles receive their motor information, or told to move, by the mandibular division of the trigeminal nerve. So the mandibular division is the only one of those three pieces which actually has a motor component to it. The ophthalmic and the maxillary divisions are pure sensory. They don't move any muscles. It's the mandibular nerve that moves those four muscles of mastication. The fifth muscle that you see listed here, the buccinator muscle, becomes an important landmark when we're giving local anesthesia, but it does not receive its motor information from the mandibular nerve. It receives its motor information from the facial nerve. This slide shows you the location of the masseter muscle and the temporalis muscle. This is the vicinity of the parotid gland because what you see here is the parotid or Stenson's duct. So recognize that the parotid gland is overlying most of the body of the masseter muscle, and that the duct bringing saliva from that gland runs across the masseter and through your buccinator muscle. Here's the buccinator muscle right here as you would view it from the outside. Also notice that the masseter muscle wraps itself around the angle of the mandible, and so does the parotid gland. This becomes important later on. In this view, you're looking at the mandible and the zygomatic arch cut away, so the masseter muscle would normally be sitting here, and on the inside of the mandible runs the twin of the masseter muscle called the medial pterygoid, and the lateral pterygoid muscle runs in a horizontal direction above it. Notice that the medial pterygoid muscle goes out and away from the mandible, toward the center of your skull. So when you're giving anesthesia on the mandible, your needle is passing lateral to that muscle. You're headed for here, and you want to stay to the inside of that muscle. The pterygomandibular raphe, which is the joining of the buccinator muscle, which is what forms most of the inside of your cheek, and this muscle right here called the constrictor pharyngeus. This raphe becomes a very critical landmark when giving an inferior alveolar block. This diagram will show you have to kind of orient yourself when you look at this. You're looking at the lingual view of these teeth, so this is kind of like you're sitting on the patient's tongue. Here's the medial pterygoid muscle. This is the inside of the ramus. There's the lateral pterygoid muscle. And the mandibular foramen is located right here. So you want your needle to pass lateral to that medial pterygoid muscle. You don't want to be putting anesthesia into the medial pterygoid muscle. The patient could get a condition called trismus, where the muscle goes into spasm and then they can't open their mouth very well. As I mentioned previously, the buccinator muscle joins a muscle, the upper muscle of your throat, called the superior constrictor pharyngeus muscle, at a structure called the pterygomandibular raphe, and this is a very important landmark for us when we give an inferior alveolar block. You want to remember that your needle is always going to be inserted lateral to this raphe, so it becomes very important to be able to locate it in the patient's mouth. Here's the mucosal tissue. This is the buccinator muscle. This is the constrictor pharyngeus muscle that forms, as I said, the back wall of the throat. And this is where those two muscles join together. It's kind of a thick, fibrous structure. It's very noticeable in most people's mouths, and when you learn to give an IA block, you're going to really like it when your patient has a visible pterygomandibular raphe. This will show you in this drawing. This is the raphe, and a lot of people, it almost has a backwards S-shaped curve to it. It doesn't go up straight in a lot of people. So again, the insertion or deposition site for an IA block is always going to be to the outside or lateral to that raphe. Here's a picture of it in a real human. You'll notice, as I said, it curves upward, inward, and then back out again. So your point of insertion, this is your buccinator muscle, this is your constrictor pharyngeus muscle, and your point of insertion is always going to be lateral, right here. You can take your needle and just kind of move that out of the way and make sure you go in here. The vasculature of the head and neck becomes important because we want to make sure that we understand, in most instances, in particular, the inferior alveolar and the posterior superior alveolar. When we give these two injections, we have a fairly large blood vessel that is accompanying the nerve. The blood vessel is in the same vicinity that we need to deposit our anesthetic, so it's critical to aspirate when you give any injection. But the injection that carries the highest percentage of positive aspiration is this one, the inferior alveolar block, and that's because the inferior alveolar artery is running side by side with that nerve. When we look at our arterial blood supply, we have to start with the external carotid artery. There are 8 main branches to it, but the maxillary artery is the branch that we are most concerned with in dentistry. Here's the external carotid artery right here, and everything you see off of it here are branches of it. You'll notice that we have a branch going down into the molars, but there's a significant vessel right here. We also have a branch coming up through that infraorbital canal that I mentioned, and it comes down to the teeth the same way that our nerve supply does. Here's our inferior alveolar artery entering the mandible at the mandibular foramen, the same place as our inferior alveolar nerve. Here's the mental nerve coming out the mental foramen, the same as our mental nerve. I might be saying nerve instead of artery, but I'm sure you get what I mean. If you were looking at this and it was nerves, they're running side by side. So wherever you're making a deposition for anesthesia, beside the nerve is a blood vessel. So we need to be aware of that. Here's a closer up look. There's the external carotid artery, here's the maxillary artery, and here's the inferior alveolar artery entering the mandible at the mandibular foramen, running underneath the roots of these teeth just the way the nerve does, and sending a branch out the mental foramen. The posterior superior alveolar and infraorbital arteries basically follow the same pathway as the nerves. So here's the posterior superior alveolar nerve entering the PSA foramina, where we're putting our injection of anesthesia. Here is the infraorbital artery passing along the floor of the eye orbit, sending the terminal branches out the infraorbital foramen. So notice you're going to be putting an anesthetic right here. And here are the two branches of the infraorbital artery that go down to the rest of our teeth, the middle superior alveolar artery and the anterior superior alveolar artery, just like the nerve supply. The facial artery is a major vessel off of the external carotid artery that comes up the side of our neck and right at the angle of our mandible crosses over and goes up the side of our face all the way up to the side of our eye. In some individuals, if you place your hand here very gently and walk it along the lower border of the mandible, you can actually feel the pulse from the facial artery. The lingual artery is the only one of these arteries that takes a slightly different course than the nerve supply in the same vicinity, but it's important for you to recognize that you have a very major artery that runs along the floor of your mouth and up into the body of your tongue. And just like the lingual nerve sends sensory messages from the tongue, the lingual artery brings blood supply to and from the tongue. This is probably the most critical structure for you to understand in terms of the vasculature of the head and neck, its location and its significance when we give anesthesia on the maxilla. It is called the pterygoid venous plexus. In most individuals, it's probably about the size of a dime, maybe a little larger, and the vast majority of veins bringing blood back from the oral cavity are draining through this plexus. It's just like a little collection area where there's like a whole lot of small veins all captured in one small place. So you'll notice it says here, structures of the oral cavity drain through the pterygoid venous plexus. The reason it's important to us is when we do a posterior superior alveolar block, if we inject up too high or too far back, we could pierce one or more of these little veins that go through the plexus, and then wherever we made a needle hole, the blood circulating through that plexus is going to come out the hole we made with the needle. I don't want to scare you, I just want to let you know its location, and it is one of the reasons that doing a PSA block carries a higher than usual risk of the patient developing a hematoma. The hematoma is when we've made a hole in a vessel wall and then the blood comes out the hole that we made and pools in the vicinity. The other thing that's important with the venous plexus is it has what is called an anastomosis. That's a connection. That means that the venous plexus connects with another structure called the cavernous sinus. The cavernous sinus is located inside the brain. It's an intracranial structure. So it's important to recognize that if we were to pierce the pterygoid venous plexus, because this plexus has a connection with what's up inside the brain, should we transmit any bacteria into that plexus of veins, it could travel backwards into the brain because the veins of our head and neck have no valves to prevent the backward flow of blood. Here's your buccinator muscle. This actually, in my opinion, makes that plexus of veins look a little bit larger than it really is. But here's your maxillary sinus, and the plexus of veins is located up behind the infratemporal surface of the maxilla. Again, here is the posterior superior alveolar artery. This diagram, I think, gives a clearer indication of the location of the pterygoid plexus, although in many people it's actually a little more forward and closer to the area where we put our posterior superior alveolar injection. The cavernous sinus is an area inside the brain that's part of the venous drainage in the brain. And here again you see the word anastomosis. That means there's a connection There are several areas where the blood supply inside the brain connects with the blood supply outside the brain. The one that's most important to us is the anastomosis between the cavernous sinus and the pterygoid venous plexus. It also has a connection with the facial vein in the inner corner of the eye, but what's most important to recognize, as I've mentioned, is that should any kind of bacteria or virus be injected or get into the pterygoid venous plexus or the facial vein, because there's no valves to stop the backflow of blood within the intra and extracranial blood supply, the infection could get into the brain, resulting in meningitis. Also, the cavernous sinus has several cranial nerves that pass through it. They could become damaged, or a fatal blood clot could be set up. This slide shows you they've grayed out the pterygoid venous plexus, and here's the cavernous sinus, but you can see that these veins connect with one another. This slide shows you the 12 cranial nerves, and I don't think that you need to be familiar with the vast majority of them. You certainly, that's why I put the ones in bold that I think are most important. I'm going to cover the trigeminal nerve in much greater detail, and mention something that's very important for us to understand about the facial nerve when we give local anesthesia. I don't think that you'll be tested on the nerve exam in terms of the other cranial nerves.